relevant faculty disclosures for accredited scientific sessions can be found online at the MDS Congress website. Please do post your questions to the faculty in the chat feature and be sure to stay until the end of this session for a live discussion and a Q&A session. And finally, please take a moment to provide feedback in the session evaluation, for which you can find the link in the chat feature or in the Scientific Program tab in the Virtual Congress platform. Thank you, and please enjoy your session.
I'm Hiroshita Watanabe from Department of Neurology, Fujita Health University. It's a great honor for me to be here. I'd like to thank all the committee members for giving me this opportunity. Today, I'd like to talk about diagnostic approach to ataxia. Learning objectives are to summarize the diagnostic approach to patients with ataxia. Today's my talk has 3 parts. First, I'd like to discuss what is ataxia. Second, I'd like to show the diagnostic approach to acute, subacute ataxia. Finally, I'd like to show the way to diagnostic approach to chronic progressive ataxia. Let's begin with first topic. Ataxia is derived from the Greek meaning without order. As such, it is a broad, non-specific description. People with ataxia show movement that are impaired in terms of their timing, extent, and variability. There are 4 types of ataxia, namely frontal lobe ataxia, sensory ataxia, vestibular ataxia, and cerebral ataxia. Cerebellum integrate frontal lobe information, proprioceptive information, vestibular information. Interestingly, quite different anatomical involvement will show the same gait ataxia. So we need clinical differences among cerebral, sensory, and vestibular ataxia. Cerebral ataxia patient is often unable to stand with feet together, even eyes open. Romberg test is generally absent. Dysarthria may be present. In patients with sensory ataxia, impaired position sense and absence of ankle reflex are characteristics. Vestibular ataxia patient will not show limb ataxia, but show characteristic nystagmus. The slowness is an important keyword for the patient with frontal lobe ataxia. I'd like to emphasize on the importance of Romberg's test. 3 sensory systems provide their input to the cerebellum to maintain truncal stability with eyes opening, including vision, proprioception, vestibular sense. 2 of 3 systems are needed to maintain balance. I'd like to show representative procedures. The patient is asked to stand with both feet together. The clinicians ask the patient to first stand quietly with eyes open and then with eyes closed. The patient tried to keep her balance, but due to the deep sensory disturbance, she loses her balance and falls. It will be crucial to understand differences between sensory ataxia and cerebral ataxia in Romberg's test. This cartoon shows the Romberg's test in patients with sensory ataxia. During eye opening, the patient can keep standing steady. However, during eye closure, the patient can keep standing unsteadily, wobbling, or falling. Interestingly, Romberg's test in patients with cerebral ataxia showed that the patient was unstable in the stage of closing eyes and opening eyes and tend to tilt toward the diseased side of cerebellum. It will be also very important to understand the anatomy and topodiagnosis of cerebellum. The cerebellum is usually separated into the midline cerebellum and the cerebral hemisphere. Involvement of Burmese related to ataxial balance and gait and dysmetric saccadic eye movements. Involvement hemisphere is associated with ataxia of ipsilateral limb movements. Broconodular lobe involvement related to ataxial balance and gait and saccadic smooth passage, poor vestibular ocular reflex VOR suppression, slightly reduced VOR gain, and impaired VOR adaptation. Recently, several authors proposed the importance of the concept of cerebral cognitive affective syndrome. As you can see, healthy cerebellum are related to not only movement, but also cognition and emotion via universal cerebral transform conception. Interestingly, a cerebral injury patient also show not only dysmetry of movement, but also dysmetry of thought via universal cerebral impairment. Dysmetry of movement associated with an ataxia, and the dysmetry of thought is thought to be associated with a cerebral cognitive affective syndrome. Patients with cerebral cognitive affective syndrome may show impairment of the executive function, visual spatial cognition, emotion, affect, and language over and above speech. I'd like to show the imaging evidence of cerebral cognitive affective syndrome and novel concepts. BBM studies show that location of region determines motor versus cognitive consequences in patients with cerebral stroke. As you can see, a cerebral motor syndrome only patients show the damage to the anterior lobe region. In contrast, cerebral cognitive affective syndrome only patients show the damage to posterior lobe regions. This is a new concept, such as the basal ganglia and cerebellum related to nodes in an integrated network. In the motor network, putamen and anterior cerebellum support the unsupervised learning in the motor cortex, playing a role in reinforcement learning and supervised learning, respectively. In a cognitive network, dorsolateral striatum and lateral posterior cerebellum also will support unsupervised learning in the dorsolateral prefrontal cortex by playing a role in reinforcement learning and supervised learning. I think that this is a very unique concept. This part introduced the backgrounds and the common etiologies of ataxia. Polling question for audience: which is the correct sentence? Ataxia is defined as impaired coordination of voluntary muscle movement. The cerebellum and its afferent and efferent connection, the frontal lobe, the vestibular system, and the proprioceptive sensory pathway can be all involved in ataxia. It's crucial to understand the correlation between neuroanatomy and clinical features of ataxia. Presence or absence of dysarthria scanning speech and Romberg's test will be useful for differentiating among cerebral sensory and vestibular ataxia. The cerebellum is usually separated into the midline cerebellum and the cerebral hemispheres. The cerebellum will not be associated with cognitive and affective symptoms. Let's move on to the next topics. Time course of acute ataxia is over a period of minutes to days. Vascular disorders, ischemia, hemorrhage, intoxication, drugs, alcohol, toxic agents, infections, cerebritis, cerebral abscesses, and meningitis, should be considered as a cause. VII7 is an acronym for vascular disorders, intoxication, and infections. I'd like to summarize the screening method for acute ataxia. General examination, including fever, blood pressure, arrhythmia, skin eruption, diarrhea, vomiting, lymphadenopathy, will be very important. History taking for causative drug, alcohol, and toxin, such as alcohol, drugs, antiepileptic drugs, chemotherapy, toxic agent, or living habit disease, are also crucial. Blood test, ECG, chest X-ray test will provide useful information. MRI always useful, particularly for detecting lymphatic regions. However, posterior circulation territory in DWI may show negative signal changes due to the small region size, insufficient signal-to-noise ratio, and magnetic susceptibility artifact. Abnormal MRI findings not consistent with vascular territory also suggest the presence of infections such as mycoplasma, tuberculosis, and listeriosis. Lumbar puncture with extra CSF and serum will be useful. As for the viral infection, we should consider the varicella zoster, rotavirus, influenza virus, EB virus, and Coxsackie virus. Next, I'd like to consider the time course of subacute ataxia